This is going to be topic 51.3, Environmental Mountain Medicine.
Key concepts. Upon completion of this chapter, you'll understand altitude sickness syndromes, acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema, minor disorders of altitude like ultraviolet keratitis, high altitude renal hemorrhage, and Kumbu cough, role of acclimatization in preventing mountain syndromes, assessment and diagnosis of altitude sickness syndromes, and treatment of altitude sickness syndromes. So, travelers to mountain areas may encounter altitude-induced problems. Universe of mountain medicine includes bites and stings, heat and cold illness, anaphylaxis, and altitude sickness. Chief concern. Common ascent to altitude problems. We get acute mountain sickness, high altitude pulmonary edema, or HAP, high altitude cerebral edema, or HACE, levels of altitude, low altitude below 8,000 feet, moderate altitude 8,000 to 12,000 feet, high altitude 12,000 feet to 18,000 feet, and extreme altitude above 18,000 feet. Acclimatization. Person ascends in altitude, barometric pressure decreases, and this is when the barometric pressure decreases, it provides fewer oxygen molecules to his cellular environment, or there's fewer oxygen molecules available. The amount of oxygen remains the same, but the pressure on the oxygen doesn't allow it to have any push into the cellular environment. Now, Dalton's law of partial pressures, the pressure of a mixed gas is equal to the sum of the pressures of the individual gases. Now, I'm going to talk about this here for just a second because this is pretty confusing. I look at this like a pie. And %21 of that pie is oxygen. Now, if we add anything else into this pie at all, that adding could displace this 21%, make it less very easily. Also, in addition to that, if there's no pressure on this, the pressure decreases, and to the alveolar sacs perspective, and this is the capillaries, it's going across it, it doesn't have an adequate amount of push to keep the fluid that's in the interstitial space at bay. So what we get is we get a version of pulmonary edema. Acclimatization. The body compensates oxygen molecule reduction, and acclimatization is essentially we are in that climate long enough to where our body compensates for the environmental changes. A normal response to altitude, and that includes faster, deeper breathing, and these are Kussmaul-like hyperventilation, very deep, and faster, increased respiratory effort, some shortness of breath during exertion but not at rest, periodic breathing similar to Cheyne-Stokes breathing at night, hyperventilation periods with periods of apnea, and this causes frequent awakening, increased urination, increased cardiac output, higher pulmonary arterial pressure, increase in red blood cells if you're there long enough, and fluid shifting from the blood to the tissues. And that's because of less pressure on the external environment. Normal physiological response to altitude include changes in breathing and urination, pulmonary and systemic hypertension, increased red blood cell production, and that would be because of the hypoxia, faster, deeper breathing, and an increased 2,3 DPG. Now, let me kind of go through that here a little bit. As the atmospheric pressure drops, the body also starts assisting in this, and it manufactures an enzyme called 2,3-diphosphoglycerate, or 2,3-DPG. This enzyme lessens the affinity for oxygen to remain bound to hemoglobin and helps release more oxygen to tissues at lower pressures. As altitude increases and pressure drops, the body produces more 2,3-DPG, which keeps the oxygen transfer going. Major disorders of altitude. They include acute mountain sickness. Exact cause is not completely known. Pathological effects result of cerebral edema. Oxygen hemoglobin dissociation curve is involved in this. Relationships between the availability of oxygen and oxygen-carrying hemoglobin. High-altitude cerebral edema, or HACE, is a life-threatening condition. Causes an increased intracranial pressure due to reduced blood oxygen, or PO2, at altitude, and results in leakage of the fluid that compresses the brain tissue. Usual onset of this is 24 to 36 hours after the arrival at altitudes over 10,000 foot. High-altitude pulmonary edema, or HAP, is non-cardiogenic edema, or non-pump-related edema. The cause of this is increased pressure in the pulmonary capillaries. Usually occurs on the second night at a new altitude and rarely occurs after 4 days at a given altitude, and this is often preceded by HACE, or high-altitude cerebral edema. Minor disorders of altitude: ultraviolet keratitis, or snow blindness, painful eye condition. Cause on this is extreme solar ultraviolet radiation exposure. Typically occurs from not wearing no protection or inadequate eye protection in high glare conditions. High altitude retinal hemorrhages occurs frequently at altitudes above 14,000 foot. Cause is the lack of oxygen to the retina. Rarely affects vision unless the hemorrhage is very large. History. Acute mountain sickness. Symptoms on this are going to be dizziness, headache, nausea, fatigue. Headache is almost universally common in people who travel above 6,000 foot and is a key indicator of acute mountain sickness. Acute mountain sickness worsening to HAS, or high-altitude cerebral edema. Drug-induced respiratory depression like alcohol, sleep aids, and narcotics. Or HAP. Hallmarks of HAP, high-altitude pulmonary edema. Extreme fatigue, restless at night, the shortness of breath with mild exertion, and more seriously, shortness of breath while at rest. On examination, common changes in altitude: hyperventilation, difficulty breathing, or dyspnea on exertion. Respiratory pattern changes with breath-holding episodes lasting up to 15 seconds. This would be like Cheyne-Stokes-like respirations. Acute mountain sickness symptoms: loss of appetite, fatigue and dizziness, and nausea and vomiting. HAS symptoms, or high-altitude cerebral edema, difficult at gait test. Now, HAS can be differentiated from acute mountain sickness by a simple gait test or a modified Romberg's test. The individual is instructed to walk heel to toe for several steps and then asked to turn around and walk back. If the person has difficulty, the paramedic can assume that he has some degree of high-altitude cerebral edema. Altered mental status is another. HAP symptoms: pale, cool skin and peripheral cyanosis, tachycardia and tachypnea at rest, patchy crackles on lung auscultation. Precursor is a Kumba cough, dry, persistent, and sometimes debilitating cough. This is the diagnosis of altitude sickness, or the Lake Louise criteria. And the Lake Louise criteria come up with the International Hypoxia Symposium in Alberta, Canada, in 1991 produced the Lake Louise criteria, and that's where they were at whenever they had this, was Lake Louise, which lists the diagnostic criteria to make the diagnosis of altitude sickness. Clinical diagnosis of acute mountain sickness is defined as a headache accompanied by one of the listed criteria in this Lake Louise criteria. So, acute mountain sickness with headache with anorexia, nausea or vomiting, fatigue or weakness, and so on. High altitude cerebral edema, mental status changes, or ataxia. The gait is the easiest way to figure this out. High altitude pulmonary edema, dyspnea or difficulty breathing at rest, cough, weakness, chest tightness or congestion, crackles or wheezes, central cyanosis, tachypnea, and tachycardia. Treatment. Very simple. Acute mountain sickness: rest, fluids, and over-the-counter analgesia. Diamox or acetazolamide, my apologies, 125 milligrams by mouth over 12 hours, increases the bicarbonate secretions and increases the acidity of the blood, and this will help with some of the AMS or acute mountain sickness symptoms and also help you to acclimatize faster. Do not proceed any higher until 100% symptom-free. Not resolved within 24 hours. Descend to a lower altitude. Development and severity depends on the ascent and the physiology that's at play. Treatment for high-altitude cerebral edema, oxygen, 4 to 6 liters by high-altitude oxygen apparatus. Dexamethasone acts as an anti-inflammatory, decreasing swelling. Evacuate to last asymptomatic or where they had no symptom altitude and lower. Treatment for high-altitude pulmonary edema, rapid descent, 2 to 3,000 foot lower than symptom location. Supplemental oxygen. Combination of supplemental oxygen and descent effectively raises the PO2 and rapidly reduces the symptoms that are seen. Medications would be things like dexamethasone, albuterol, and nifedipine. Now, nifedipine, what it does, nifedipine is a smooth muscle dilator, which by decreasing the amount of pressure in the pulmonary artery, it decreases the amount of pressure in the actual pulmonary trunk, so we don't get a movement. If the pressure is decreased this way, then the fluid won't flow into here. So if we decrease the pressure here, there's probably going to be a balancing act between the alveolar sac and the capillary level. And then hyperbaric chambers, a Gamow bag, sleeping bag-like device that can be inflated to mimic pressures at altitudes approximately 2,000 foot lower than you're currently located. The treatment of Kumbu cough, patient needs to rebreathe their own humidity. Simple balaclava will work, and this is something that just kind of covers your face so that you breathe your own humidity. Special ski mask is more functional. Metallic net with a cloth shell maintains its shape under extreme conditions. An evaluation, less common disorders. Several must be considered if their patient is actually having a cerebrovascular accident or TIA, deterioration due to prolonged high-altitude stays, chronic conditions affecting their heart, lungs, and blood vessels. And then as far as disposition, patients with HAS or HAP transport to facilities familiar with the conditions, often by helicopter. Serious side effects of high-altitude travel. Considerations on this should be patients should try to attempt to stay healthy, control ascent rate. If there's pharmacological agents, administer those. And then nutrition and hydration must be paramount. So, in conclusion, altitude-related ailments is a consistent threat to travelers, trekkers, and adventurers. Acute mountain sickness, early recognition and treatment can decrease morbidity and mortality.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, SmithR at SamaritanEMSOK.com or 405-492-8243. Thank you.